when they describe what our red blood cell count is, which is very important, they express it in millions of red blood cells per cubic millimeter of blood. And obviously, we said the normal value is 5 million, and yes, I want you to know that number. And it's always written in exponential notation form. They would actually write 5 times 10 to the 6th is how it would be written per cubic millimeter. And if somebody has a significantly lower number of red blood cells than is normal, then we say they are anemic. They don't have the normal number of red blood cells to carry oxygen in the blood. We had explained that what's a cubic millimeter. So I first explained what a cubic centimeter is. We said that's a box that is a centimeter tall and a centimeter deep and a centimeter wide, and it actually holds a volume of 1 milliliter. So commonly, as we said last time, if somebody needs 5 milliliters of a drug, they might say 5 cc's. It means the same thing, cubic centimeters. A millimeter, a cubic millimeter is 1/10 of a centimeter, at least each millimeter. So this is a box that's a millimeter tall, millimeter deep, and a millimeter wide. That cubic millimeter holds a volume of a microliter of fluid, 10 to the minus 6, the millionth of a liter. So really what we're saying is that every cubic millimeter or microliter of blood has 5 million red blood cells. And we also pointed out last time that since there's 5 million in each microliter of blood, now you can appreciate that there's really close to 20 trillion red blood cells. We said 17, close to 20 trillion red blood cells. Now, of course, the function of red blood cells is to transport oxygen and CO2 by binding to hemoglobin. That we have to make 2 million new red blood cells every second to replace the 2 million that are dying each second. You don't have to know that number. Erythropoietin. Erythropoietin is a hormone secreted by the kidneys. So now we know the kidneys secrete a hormone called renin, involved in the renin-angiotensin-aldosterone homeostatic reflex, and they secrete also another hormone called erythropoietin. What's the clinical name for a red blood cell? Erythrocyte. So erythropoietin is a hormone that stimulates erythropoiesis, which literally means the production of erythrocytes in our bone marrow. And we did mention that they commonly give people this hormone who either they have failing kidneys, since their kidneys don't work, they're not able to secrete this hormone. We also said they give it to people who are undergoing chemotherapy because chemo damages bone marrow. And because it damages the bone marrow, the person's red blood cell counts drop, their white blood cell counts drop, their blood platelets drop, and so they are anemic. Their red blood cell count drops, so they give them this hormone to stimulate increased production of red blood cells. Red blood cells only live 4 months. We said that's because they have no nucleus, and they have no genetic information. If they were to have a nucleus, these red blood cells are really the smallest body cells in our body. The only cells that are smaller than a red blood cell are sperm. And if they had a nucleus, it would fill up the whole cell, so it wouldn't be able to carry oxygen. So, but therefore, they only live about 4 months. We explained last time on the page 8 that the red blood cells that circulate as they get damaged and old, they are removed from the bloodstream by macrophages, large phagocytic cells that are in the liver, especially, also the spleen and bone marrow, but especially the liver. And they break down the hemoglobin into hemoglobin. And the globin, anytime we have the word globin or globulin, it means protein. It's just broken apart into amino acids. The iron is removed from the heme, and what's left when you remove iron, that atom from heme, is called bilirubin, and its color changes. If you've had chemistry classes, you know that metals can affect color, right? Anything that has like copper in it is usually blue or green. Things with iron are like red and orange. Anybody know that in chemistry? So, anyhow, so that's what gives the heme or the hemoglobin its red color. And the bilirubin is secreted by the liver with the bile, and that is what gives the bile its kind of yellowish green, greenish yellow color. The iron is recycled back to the bones by that protein made by our liver called transferrin, which is a transport protein in the blood. Anyhow, we talked about that last time. On the bottom of the page 7, so anemia. The definition of anemia, by definition, is a decreased number of normal red blood cells. And if you have fewer normal red blood cells than you should, then you have a reduced capacity to carry oxygen in your bloodstream. So as we learned near the end of class last time, you might say, well, why is that important? If you're carrying less oxygen in your blood than normal, the ability of your cells of your body to carry on aerobic cellular respiration is reduced. And therefore, your production of ATP, that gasoline that powers everything in your body, is going to be reduced production of ATP. So no wonder people who are anemic feel tired because they produce less ATP. They also feel cold because cellular respiration is the major source of heat in our body as a byproduct. Now, not only do they measure red blood cell count, but they also even measure the amount of hemoglobin in our red blood cells. There should normally be 15 grams of hemoglobin in every 100 milliliters of blood, or 15%. Percent meaning grams per 100 milliliters. Yes, I want you to know that number, because when they measure your hemoglobin level, if it's lower than normal, that's another indicator of being anemic. In fact, somebody could have the right number of red blood cells, but less hemoglobin in the red blood cells than normal. Now, why? Why might they not have the right amount of hemoglobin? On page 9, there are many, many, many types of anemia. And here's one that I think many of you are familiar with: iron deficiency anemia. Haven't we learned that iron is part of the hemoglobin? So somebody might have the right number of red blood cells, but because they're not getting enough iron in their diet, they don't have the normal amount of hemoglobin in their red blood cells. So even if their red blood cell count is normal, their hemoglobin content in their blood might be less than normal. There are a whole bunch of other nutrients that are needed in order for your body to make hemoglobin. Those of you who might have had a nutrition class, who's had nutrition? So you might have learned that you need a B vitamin called vitamin B12 or cyanocobalamin. It actually contains the metal cobalt. And you need that in order to make red blood cells. So if you don't have enough vitamin B12, you'll also be anemic. And that happens to be known as pernicious anemia. Another B vitamin you need, I didn't even write it, you don't have to know it, is folic acid or folate. So somebody could have many causes of being anemic. Iron deficiency anemia, B12, vitamin B12 anemia, folic acid anemia, because there's many nutrients that are needed as coenzymes. Another one that I do want you to know is aplastic anemia. This, I wrote, occurs with chemotherapy. We've said chemotherapy, which is the chemicals they give to people who have cancer to try to kill the cancer cells, always damage the bone marrow. And therefore, there's a degeneration, deterioration of the bone marrow, resulting in decreased number of red blood cells. That's called aplastic anemia. And then another type of anemia, totally different from these others, is sickle cell anemia. Sickle cell anemia is a genetic disease. This is a genetic disease. It's a genetic disorder. In sickle cell anemia, the person has a genetic inability to make normal hemoglobin. In other words, their red blood cells produce an abnormal form of hemoglobin. And in fact, the whole red blood cell is misshapen. Instead of being a small round cell, it looks what they refer to as sickle-shaped. And it just doesn't carry oxygen like normal. That's why it's called sickle cell anemia. The person's anemic. Now, there's no treatment for this. There's no cure because it's a genetic defect. And it means literally they've got a defective form of hemoglobin that won't carry oxygen like normal. So there are a lot of different causes. This is just the beginning of the types. Okay, let's move on to talk about blood platelets or thrombocytes. Blood platelets, which we have spoken of previously, are really not cells, but they are little pieces of cells that are released from the bone marrow. There are these really large cells in your bone marrow. I'm not asking you to know the name of the cells. They're called megakaryocytes. And they break off little pieces of cytoplasm that is released into the bloodstream. And that's really what a platelet is this little piece of cytoplasm, fragments of cells. There is a hormone that can stimulate the production of blood platelets in our bone marrow. It's called thrombopoietin. It's produced by our liver. So we had mentioned earlier about erythropoietin produced by our kidneys. Again, what are we noticing? We're noticing this idea of hormones. It looks like almost every tissue in the body is producing hormones. Now, an important term I'd like you to know is thrombocytopenia. The suffix ending penia, and we're going to see this term reappear over and over. Penia means lower than normal. So if somebody has a lower number of thrombocytes than normal, that's called thrombocytopenia, and that's going to impair their ability to form blood clots, and they'll tend to bleed easily. So in fact, somebody who's undergoing chemotherapy, which we said damages their bone marrow, not only is anemic, but they also suffer from thrombocytopenia or reduced blood platelet count. Has anybody known somebody who had cancer and taking chemotherapy and had low platelets? So they're anemic, they have low white blood cell count, and so on. Now, the next subject is hemostasis. And that word just means the control of bleeding. So I want to walk you through the control of bleeding. And there's basically three main steps. They're right here. 1, 2, 3. When you cut a vessel, the first thing that the vessel does is it spasms. It constricts. And the purpose of that is to reduce the amount of blood gushing out of the vessel. There is a chemical involved in that, but I won't test you on it. It's called thromboxane A2, but I won't ask you to know it. Just know that when you cut a vessel, the first thing it tends to do is spasm or constrict to reduce how much blood's flowing through it. The second thing, which we've actually learned about previously, is the formation of a platelet plug. And I want to remind you where we learned about this. This goes back to page 184A. If you want to even go back to it, you could. So back on page 184A. So we even had to know this for the test we just took. So we did learn that when a vessel is cut, the rough edges of the vessel basically cause these platelets that are moving through the bloodstream all the time to attach or aggregate. And that forms what's called a platelet plug. All right, so this forms a plug. It stops the amount of blood gushing a little bit, but that's not really the main thing that's going to stop bleeding. What the platelet plug does is these platelets, or thrombocytes, release a chemical called Platelet Factor, PF. And that initiates a series of chemical reactions we learned that culminates in the formation of something that looks like a spider web, known as a fibrin clot. And that's really the third step in this process. So here's what we wrote on page 9. We wrote, so there is the formation of this platelet plug. The platelets attach, they adhere or aggregate to the cut wall of the vessel, forming a platelet plug. And now I can tell you how aspirin works in reducing blood clotting. Many of you know that people who are prone to blood clots are taking a little aspirin every day. Aspirin interferes with the attachment of the platelets. Now, your first thought is, well, why do you want to stop platelets from attaching? Because that's going to prevent blood clotting. Let me remind you, we really don't want to. We don't want to really stop the platelets from attaching to a cut wall of a vessel. The reason why the person's doing it is they've got, as we saw in 184B, they've got atherosclerotic plaque. And we know that the platelets are attaching and aggregating to this rough surface of the plaque. And as they do, they start to release that platelet factor, and that leads to a thrombosis, a blood clot in a coronary vessel, causing a heart attack, or a blood clot in a cerebral vessel, causing a stroke. So they want to give them this aspirin that reduces the tendency of the platelets to attach. Now, of course, it is going to mean that they won't tend to attach to the cut walls, the rough edges of a cut vessel. So that's one of the adverse effects. That's one of the side effects that we don't want, but it's going to happen because they're going to tend to bleed a lot when they're cut. So whether you're a future nurse or dental hygienist, these people on aspirin are going to tend to bleed more. That's not why we're giving it. But we know that we want to reduce this risk of blood clots forming because of atherosclerosis. Everybody clear on that? So, but obviously you just don't get blood clots, period. There are all kinds of other drugs like aspirin. If you've heard, I'm not testing you on this, of drugs like Plavix or Agrinox. They work similarly to aspirin. They're just more powerful. Now, the third step, we said, is the formation of that fibrin clot. And this is actually known as coagulation, the forming of the fibrin clot. So here we wrote the blood platelets release this PF, or platelet factor. And incidentally, not only do the blood platelets release this chemical called platelet factor, but the injured cells of the wall of the vessel release a chemical called tissue factor, or TF. And both of these, PF, platelet factor, and TF, tissue factor, both have the same effect. They activate a protein circulating in our bloodstream called prothrombinase. Now, like almost all proteins in our blood, it is made by our liver. So both PF, platelet factor, which we have reviewed, released from blood platelets, and tissue factor, released by injured cells of the wall of the vessel, both have the same result. They commonly refer to the release of platelet factor as the intrinsic pathway, and they commonly refer to the release of tissue factor as the extrinsic pathway. Won't make a big deal out of that. But they both lead ultimately to the same result, activation of prothrombinase. If you jump to page 11, on page 11 at the top, so once prothrombinase has been activated by tissue factor and platelet factor, obviously from its name prothrombinase, it's acting as an enzyme, and calcium serves as a coenzyme. Remember how we've learned that calcium is needed for blood clotting? This is the role. So together, prothrombinase acting as an enzyme, calcium as a coenzyme, cause the conversion of another protein circulating in our bloodstream called prothrombin, and converts it into thrombin. Now, since this is a protein in our blood, where do you think it was formed? The liver. So there's all these proteins in our blood. Lots and lots of them. And almost all of them are made in the liver, and a lot of them are involved in blood clotting. So prothrombinase converts prothrombin into thrombin, and thrombin converts another protein in our bloodstream called fibrinogen into the fibrin clot. So that finally is the forming of that spiderweb clot, the fibrin clot. So, and where do you think fibrinogen, that protein, was formed? It was produced and secreted by the liver. So we've got all these proteins. So if you're thinking, my gosh, it seems like this blood clotting thing is like to form a fibrin clot. It's like one thing leads to another thing, leads to another thing. Yes, you're right. In fact, if you look on page 12, page 12 is the actual blood clotting mechanism. I know some physiology professors who actually make their students learn the whole thing. All right? And depending upon what you go into, you might have to eventually learn the whole thing. This is the whole sequence of reactions. It is really a whole long cascade, a long chain reaction. And look at all the blood clotting factors. So it's not just one or two or three. So when we learn the renin-angiotensin-aldosterone reflex, this one makes that one look easy, because this one's a lot more complicated. And here you can see this is called the intrinsic pathway and the extrinsic, and here's the common pathway. I'm not asking you to know this. So what am I asking you to know? Back on page 9, we asked you simply to know that the blood platelets release platelet factor, and the injured cells of the wall of the vessel release tissue factor. Both activate prothrombinase, and on page 11, the common pathway is once prothrombinase has been activated, it, along with the calcium-active coenzyme, converts the protein in our blood called prothrombin into thrombin, and thrombin finally causes the conversion of a protein, a soluble protein in our blood plasma. It causes it to solidify, to precipitate, and form this fibrin strand, this fibrin clot. What does that fibrin clot actually look like? If you look back on page 10 at the bottom, this is the bottom of page 10. It really does look like a spider web. This is a protein. This is the fibrin protein. And basically, as we've said, when that fibrin clot forms, so that basically stops the blood from flowing through this vessel and coming out. Now, we'll also remind you of what we learned back on page 184A. When the wall of the vessel is repaired, the cells, as they heal in the wall of the vessel, release a chemical called TPA, tissue plasminogen activator. And that activates another protein circulating in our bloodstream called plasminogen and turns it into plasmin. And plasmin dissolves that fibrin clot. That's called fibrinolysis. And as the clot is dissolved, blood now is able to flow through this repaired vessel. So we summarize that for you on page 11. On page 11, this process in the middle of page 11 of dissolving the fibrin clot is called fibrinolysis. Plasminogen is activated by TPA, tissue plasminogen activator, into plasmin, and plasmin dissolves that clot, which is called fibrinolysis. Okay, and of course, where would plasminogen, that protein in our blood, be produced and secreted by? The liver. All right, so much for blood platelets. Now, before we go any further and talk about the white blood cells, let's return back to page 6. And back on page 6, so last time on page 6, there's this kind of overall diagram that I kind of like, and we analyzed plasma. So I'm not going to do that again. You can watch the video of it if you'd like to see it. And then we said we have the formed elements. And the reason why and the formed elements include the red blood cells, the white blood cells, and the platelets. The reason why on this diagram they use this term formed elements instead of cells is because while red blood cells and white blood cells are cells, platelets are really not cells. They're little pieces of cells. So that's why they use that term, formed elements. Now, we've talked about red blood cells We know that the normal red blood cell count is about 5 million per cubic millimeter, and the job of red blood cells is to transport oxygen and CO2 in our blood. Blood platelets we've talked about, they're also known as thrombocytes. They play a key role in blood clotting. So now we want to take a look at white blood cells. The normal white blood cell count is about 7 times 10 to the third, which is 7,000 white blood cells per cubic millimeter of blood. Notice how we measure red blood cells in the millions per cubic millimeter, whereas the white blood cells are measured in the thousands. So we have many fewer white blood cells than red blood cells. I'm not asking you to know the blood platelet count. Now, there are 5 major categories of white blood cells: neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Let's just kind of summarize them, and then we'll tell you in more detail about them. The neutrophils are the small phagocytes. They are very important in swallowing up things like, especially bacteria. And they make up over 60% of our white blood cells. More than half of our white blood cells are neutrophils. The second major type of white blood cells are lymphocytes. Lymphocytes make up about 25% of our white blood cells, and they are responsible for our immune response, which we'll expand upon. If you had micro, you should have learned a lot about that. The other 3 remaining types of white blood cells we have very small percents of. After all, if neutrophils make up 60% and lymphocytes are 25%, that's 85% of your white blood cells between those 2. So the other 3 make up a very small percent, so I'm not asking you to know their percent. They're just small. The monocytes are the big phagocytes, the macrophages. They're the macrophages. The eosinophils are the name of the white blood cells that phagocytize allergens. Have we ever learned what an allergen is? What's an allergen? Okay, an allergen, the way we defined it way back in section C, when we first talked about inflammation and fever, is it's a harmless foreign agent. Something that's foreign to your body, but intrinsically harmless. So an example would be pollen from a flower. All right? Or some people have allergic reactions to foods or even medicines. So I would never call a bacteria or a virus an allergen. They're not harmless. But pollen, okay, some people are allergic to fur. Does that damage you? No. Most people are not allergic to fur, but some people are. So that's an allergen. So eosinophils swallow them up. And the last of the white blood cells are basophils. Basophils release 2 chemicals that both start with the letter H, histamine and heparin. Histamine, of course, is a chemical mediator of inflammation. We know that it's released any time you have inflammation, including allergic reactions, and it dilates all the vessels in the body. It can lead to anaphylactic shock. And heparin is an anticoagulant. We had mentioned that heparin is used in the hospital to prevent blood clotting. Well, we have white blood cells, basophils, that naturally produce heparin. So there are a lot of cells and a lot of chemicals involved in blood clotting. Okay, so that's the big picture. So what we want to do is look at this in more detail. Let's go back to page 11. So back on page 11, white blood cells or leukocytes. So white blood cells are nucleated cells that behave like amoeba. Now, one of the things that I actually teach my students when I teach anatomy is that there are really only 2 human cells that can kind of move wherever they want. Anybody remember what those are? Sperm. Sperm have a flagellum or tail. They can swim around. And white blood cells. White blood cells can literally squeeze right out of a blood vessel, out of a capillary, and then they kind of move around, cruise around the body looking for suspicious characters. So they move kind of like amoeba through the body to swallow up or destroy bad guys. This is always where somebody asks, well, what about red blood cells? If white blood cells move, what about red blood cells? Well, the question is, do red blood cells move on their own? You'd say, well, aren't they moving through the vessels of the body? They are being pushed through the vessels of the body by the blood pressure created by the pumping action of the heart. When somebody's heart stops and their blood pressure starts to drop, the rate at which those red blood cells are flowing starts to slow down. If your heart stops, your blood cells don't keep moving through the vessels. They cannot move on their own. They're being pushed by blood pressure. So they don't move. And neither do any other cells in your body. Liver cells don't move. Kidney cells don't move. Lung cells don't move. Where would you want them to go? What do we call it when liver cells or lung cells start to move? Cancer. We say that when these cells, a lung cell, a breast cell, a liver cell starts to move, it's metastasizing. That means it's moving, it's migrating. They're not supposed to do that. They're supposed to stay where they are. Now, the normal white blood cell count is about 7,000, 7,500 per cubic millimeter, which is a microliter of blood. There is a normal range. And obviously, if your white blood cell count is lower or higher than normal, that's not normal. So we had learned the root, the suffix ending penia. Thrombocytopenia is a lower number of platelets than normal, or thrombocytes. Leukopenia is a lower number of white blood cells than normal. And that shouldn't be. What would cause it? One thing that would cause it is chemotherapy. We've said chemo damages the bone marrow. Again, if you know of anybody, unfortunately, who's had to go through chemo, they become anemic, their red blood cell count drops, their platelet count drops, so they tend to bleed easily. And let's say you called somebody who's undergoing chemo and you said, can I come over and, I'd like to come over and, excuse me, I'd like to come over and, I'd like to come and visit you. And they might say, I'd love to see you, but if you're sick, please don't visit me, because they are very vulnerable to get sick. Their white blood cell count is down. They have leukopenia. All right? The opposite is leukocytosis. And the most common reason why your white blood cell count would be higher than normal is you're fighting an infection. Don't we produce more white blood cells when we got bad guys in our body? So if somebody has an elevated white blood cell count, that's indicative that they got a bacterial or viral infection. All right, now we divide white blood cells, on this page 11, we divide white blood cells into two groups, granular leukocytes and agranular leukocytes. Now to help us understand this, let's look at page 14. Page 14. And first off, on the left-hand side of page 14, there's kind of a nice summary chart on the left-hand side that summarizes what the function of erythrocytes and platelets and neutrophils and eosinophils and basophils and T lymphocytes and B lymphocytes and monocytes are. But we're going to explain that. This shows blood. Now, those of you, when you took anatomy, all of you had to look through the microscope at tissues. And you learned that all those tissues, those histology slides you looked at, they had all been stained. Because most cells in our body are almost transparent. So they stain or dye these cells so they show up better. And in fact, we commonly use dyes to differentiate one kind of cell from another cell. Those of you who had micro did this all the time. They called that differential staining. You lose different dyes to recognize what kind of bacteria it was, right? So they do that when they look at blood. Every time, almost every time you've ever had blood drawn from you, they actually dyed some of your blood, and somebody, a cytotechnologist, actually examined it under the microscope, as we'll be learning. Now the red blood cells, they didn't have to dye because they really are red. They're one of the few cells in our body that actually have color to them, because of the iron in hemoglobin. When they dye the cells, and the two major dyes they use, you don't have to know this, is a purple dye called hematoxylin and a red dye called eosin. You don't have to know that, but those are the two dyes they use. You'll notice that here's the two groups of white blood cells. Incidentally, these are the erythrocytes, or red blood cells. Way down here, these are the platelets, or thrombocytes. These are little fragments of cells. They're not really cells. And these are the two categories. These three cells here, the neutrophils, eosinophils, and basophils, are called granular leukocytes because when they dye them, they have very prominent granules that are either purple or bluish black or red, and that's because of the dyes they've used. They're not really blue or purple or red. So these are called granular leukocytes. What are those granules that have been stained? They're vacuoles, and that's what I wrote right down here. They are actually little sacs or vacuoles that that pick up the dye. Now these white blood cells up here are labeled agranular leukocytes. A means without. They don't have granules. Now these include the monocytes and the lymphocytes. Now really, it's not that they don't have vacuoles. They do have vacuoles. It's just that the two dyes that they're using to dye the blood cells, those dyes are not absorbed by the vacuoles in these cells. So this allows them to differentiate between this group of white blood cells called agranular leukocytes and this group called granular. Now another interesting thing about the granular leukocytes is they have weird looking nucleus. You'll notice that in all three, their nucleus is multi-lobed. It's not a simple round nucleus. It's very strange. It's a multiple lobed nucleus. So on page 11, let's speak first about the granular leukocytes. And I wrote that they have granules in their cytoplasm, which are really vacuoles, and they possess a multi-lobed nucleus. Because they have this multi-lobed nucleus, they are also referred to by the name polymorphonuclearcyte. I know it's a mouthful, but it's actually very descriptive. Poly means many. Morpho means shape. Nuclear means nucleus. Cyte means cell. So literally, it is a many-shaped nucleus type of cell. A cell with a many-shaped or multiple-lobed nucleus. For short, they are referred to as PMNs or polys. And that's how they refer to them clinically. All of them are made in our bone marrow, just like where red blood cells are made and blood platelets are made. On page 13, on page 13, so let's talk about the three types of polys. Most of the polys are neutrophils. In fact, neutrophils account for 60% of all of our white blood cells. We call them the small phagocytes, because they phagocytize bad guys, especially bacteria. So they're commonly called the small phagocytes. That's what we wrote right here. Now, if somebody has a lower than normal number of neutrophils, that's called neutropenia. Penia means lower than normal. And again, that would happen in somebody, for example, who's undergoing chemo. All their white blood cell counts are down, including neutrophils. On the other hand, neutrophilia is the term they use for an elevated, a higher neutrophil count than normal. And again, the most common reason is they're fighting an infection, especially a bacterial infection. The eosinophils are those white blood cells that phagocytize allergens. They phagocytize allergens. If somebody has a higher number of eosinophils than normal, that's called eosinophilia, and that's what we see in people who have allergic reactions. Anytime you have an allergic reaction, you've got hay fever, asthma, any kind of other allergic reaction, you have increased number of eosinophils to swallow up those allergens, those substances that you're allergic to, whether it's food, whether it's medicine, whether it's fur, whatever it is that you've been exposed to that you happen to be hypersensitive to. And then the third type of poly, of which we have very few of, are basophils. Basophils are actually very similar functionally to mast cells. And you might have heard of mast cells in either anatomy, and if you had me for anatomy, you heard about it. They're found in areolar loose connective tissue. Or you might have heard about mast cells in microbiology when you were learning about the non-specific inflammatory reaction or immune response. Mast cells release histamine, and so do basophil white blood cells. Basophils are those white blood cells that release the two chemicals that both start with the letter H, histamine and heparin. Histamine, of course, is one of the chemical mediators of inflammation that contribute to redness, swelling, and pain. And heparin is an anticoagulant. All right, we've just spoken of the, well, let's look at our picture again on page 14. We've been speaking about neutrophils, which make up 60% of all your white blood cells, and the eosinophils that swallow up allergens, and the basophils that release histamine and heparin. On the top, what about the agranular or non-granular leukocytes? There are the monocytes and the lymphocytes. Monocytes are the largest of all the white blood cells, and they act as macrophages, the big phagocytes. And then there are the lymphocytes, and the lymphocytes, interestingly, are the smallest of all the white blood cells. They're the smallest. They are just slightly bigger than red blood cells. Slightly bigger than red blood cells. Now here it shows two types of lymphocytes. We divide lymphocytes into two major categories, T and B lymphocytes, or T cells and B cells, and then they are further subdivided, as we'll see. Back on page 13, at the bottom. So at the bottom of page 13, the non-granular leukocytes or agranulocytes include monocytes, which are the macrophages, the largest of the white blood cells. They are produced in our bone marrow. And that takes us to, on page 15, the lymphocytes.